2022. The Insurance Committee of the Tennessee House of Representatives is now in session. Mr. Clerk, will you call the roll?
Representatives Carr, Sapicki, Freeman, Hawk, Hicks, Hodges, Johnson, Lafferty, Mitchell, Powers, Rudd, Smith, Terry, Thompson, White, Vice Chair Rudder, Chairman Kumar.
Here.
Mr. Chairman, you have a quorum.
Thank you, Mr. Clerk. Members, do we have any personal orders? Chairman Terry?
Thank you, Chairman, and I'd like to welcome you back. We had prayers for you and your family in their absence, and I'd like to welcome you back to the committee and just let you know that in your absence, the vice chair set a very high bar for this committee. So, but thank you for appreciate you coming back.
Thank you. On a personal note, I'm grateful for good wishes and prayers we've received because of family illness. Things are better. And when things are difficult, I remind her that this is a sweet time of our life, that we are helping each other. And that goes well. And certainly, thank you, Vice Chair Rudder, for your good wishes and your work also. Thank you. Chairman Powers.
Thank you, Mr. Chairman. I do have a couple of people here. One is going to be speaking here in a minute, Raywin Snodderly from my district, and we're always glad to have her. And they brought her mom with her that I went to school with many years ago. I think we went to school together for a little bit. Anyway, she's up here with her today, and then Raywin will be speaking later, but we're glad to have you from Campbell County today. Thank you.
Good. Any other personal orders? Seeing none, members, just to update you, we do have a presentation about and discussion about the Pharmacy Benefit Manager bill that we passed and the difficulties with it in current practice. But before that, we'll take up our calendar. We have two bills on the calendar. First one is House Bill 1719 by Chairman Reedy. We have a motion and a second. Chairman Reedy, you recognize.
Thank you, Mr. Chairman and committee. But first, if I may, I just want to publicly thank the ambulance service providers across the state. We've got a few of those folks with us today. And if you were on the 8th floor, you got to meet one-on-one with a lot of them. But anyway, I appreciate their service to our state. Mr. Chairman and committee, it's my annual bringing back of the ground ambulance bill, where we have the ground ambulance assessment extension for another year. Without using any state dollars, the ground ambulance services pays into a fund that draws down over $20 million in federal fund that is then paid back out to these services based on their Medicaid transport. Mr. Chairman, I will answer any questions that the committee might have.
Members, you have any questions? The question's been called without objection. We are voting on House Bill 1719. All those in favor, please say aye. Aye. Opposed? Ayes prevail. The bill goes on to calendar and rules.
Thank you, Chairman.
Thank you.
Committee.
Correction, the bill goes on to finance. Chairman Powers, you're recognized.
I'm sorry, I'm out of order. I forgot to mention someone. I thought he'd already left. Now he has left. Okay, I was going to mention Andrew Reed, but okay, he just walked out the door, but he's from my district. Sorry, Mr. Chairman. I was going to recognize him, but he's with EMS, and he does a great job up there in our county. And there he is again.
Yes.
Okay. Hey, Andrew. Thank you for coming today.
Thank you, Chairman Powers, and thank you, Andrew. Our next item 2 is House Bill 1752 by Chairman Smith. Do we have a motion? And a second. Chairman Smith, you're recognized.
Thank you, Chairman Kumar, and I am going to ask for a roll call vote on this particular piece of legislation. I want to make sure that patients all over Tennessee realize that we are a body that does prioritize their care. and not just that of some of the interests that walk these halls. House Bill 1752 is a bill that takes current code and it expands the definition in one small way, but a very material way. In the state of Tennessee, there are 20 counties that have no access to hospitals, and 17 of those counties have no access to emergency departments. Lake, Crockett, Haywood, Fayette, McNairy, Stewart, Chester, Lewis, Clay, Moore, Jackson, Pickett, Morgan, Van Buren, Grundy, Sequatchie, Meigs, Union, Granger, and Polk. These are counties that have no access to emergency rooms or hospitals. And as defined in code, emergency services means healthcare items and services furnished in a hospital. And while I do want to take this moment to applaud the good behavior of some of our colleagues and partners in health insurance by covering items and services that are rendered in an emergency situation in doctor's offices, in urgent care centers, there have been times where those have resulted in surprise bills. There have been efforts in the last 18 months of one particular insurance company wanting to establish a nationwide policy to have an automatic retrospective review of any services rendered in a emergency services way. And simply what this will do, it will expand the definition to say that emergency services rendered in a hospital, also in a physician office, a satellite emergency department facility, a freestanding emergency room, or an urgent care center are those covered covered, where there is no mandate. The mandate is already in the code for reimbursement and how that's established. This only addresses the definition. And with that, Mr. Chairman, I'll be happy to take questions.
Members, do you have questions? Chairman Powers?
Thank you, Representative Smith, for bringing the bill and appreciate your work on this. I do have a question. It may have to be answered by the insurance industry. I think you and I had talked about this at one point before. If someone goes to an urgent care or that type of situation, then they are immediately transported to an emergency room to maybe they have a heart attack or something like that, where they have to have an EKG at the urgent care. Then they go to the emergency room and they have to have another EKG. Are both of those going to be covered on most insurance plans? Because I'm not sure, I think maybe some areas have a way of transmitting that information to the hospital and others may not. So I just wanted to find out from the insurance industry if this is something that's going to be, if it's a duplicate thing like that, and it probably will be, they'll probably have to run another EKG or do another test that they might have already run at the urgent care. So I'm just trying to find out if both of those would be covered on an insurance plan, or if the patient would be responsible for one or both of those.
Chairman Smith?
Thank you, Chairman Powers, and thank you for revisiting a question that we spoke about yesterday. And as you know, one of the main drivers of this, from my perspective, is not just providing care for those who don't have access, but also to eliminate surprise billing. And so already there's a risk at which, without this being codified, without the insurance company's good behavior being codified, there's a greater risk of a surprise bill if this should be denied care. And so that continues to put the rationale behind the bill. But as we talked about yesterday, this does not in any way or incapacitate the current medical chart review. There has to be documentation as already established in the existing code of the examining healthcare provider to establish that need. And so if indeed the test results are able to be transferred, then that redundancy would not be covered and it would be justifiable. But again, there's nothing specific that we're putting in here that would tie the hands of the insurance healthcare plan. It just simply protects the patient, particularly those in rural healthcare areas, or in the case of my county, in Hamilton County, from Sell Creek down to Erlanger Hospital is about a 35 to 40-minute drive, but you pass several urgent care centers. And if someone's if you've ever heard the statement, time is tissue, Why is time tissue? Because you have to administer oxygen, you have to administer aspirin, you have to deal with circulation. And so if there's a way to intervene and save that person's life along the way and get them stabilized, this just ensures the good behavior already of the insurance companies for those that are observing that and they're paying for it. And this will eliminate some of the surprise bills. Thank you, Mr. Chairman.
Chairman Powers?
Yes, and I agree with you, and I understand that. My only question was to keep from having a surprise bill, to keep from having to pay for one, like if you had to have two EKGs or two, whatever that test might be run, we didn't want the patient to end up with a surprise bill then. And that's what I was talking about. If they have to have an EKG at the urgent care, they transfer in the hospital, they have to have another one. I'm just wondering if the insurance, most plans would cover that, or would they get a surprise bill and say, hey, you've got to pay for one of these. You've had two within, 20 minutes or whatever. So that was my question.
Yes, Chairman. Smith, the question is that would there be double billing, or would one of the services be denied if two
Yes.
Well, and
tests are done?
and Chairman Kumar and Chairman Powers, that could happen now without this piece of legislation. And so the hope is to establish that care delivered in an urgent care center would fall under that type of care that would serve to stabilize the patient. And so this is in an effort to eliminate the likelihood that the greater likelihood of having a surprise bill exists without this piece of legislation. If we insert this into Tennessee Code Annotated by changing and expanding that definition, it eliminates the greater likelihood of having that surprise bill. Thank you, Mr. Chairman.
Thank you, Chairman Smith. Looking at it, it does not seem clear that it would prohibit the insurance company from denying bills that have services that were performed in duplicate.
And Chairman, if I'm recognized,
Sure.
That's exactly the truth. This is not a mandate. This is just establishing that care as documented by a overseeing healthcare provider that would be deemed to be life-saving would make sure that it falls under the emergency services. And I do want to take the opportunity to say that we're not referencing the U.S. Code 42, which is the EMTALA law. Instead, this is only talking about that care, which in that episode of care would be determined to be that which is life-saving. And again, this doesn't tie the hands of the insurance companies to make that review and make a determination, but it also adds just a notation that it is the sentiment of this body to protect patients.
Thank you, Chairman
Thank you.
Smith. Yeah, I'm still not clear. It does not specifically address that problem, does it? You recognize?
It's intended to reduce the likelihood. Instead, the intention of this bill is to provide access of care to the residents of 20 counties that don't have access to emergency departments. And sir, I'll be glad to answer any other questions of other members.
Well, Chairman Powers?
Thank you, Mr. Chairman. Would it be possible to go out of session just for a minute and have someone from the industry to maybe talk about whether that's a duplicate coverage or not, or what on most plans? I mean, is there any way to do that?
Sure, I think it's a legitimate question that we're struggling with. Do you have anybody available?
I don't. I didn't know if there's anybody in from the industry that might want to comment on that.
I don't see anybody, but I think
Okay.
specifically looking at it, this bill, to me, does not specifically address the matter of duplicate services.
Right.
We can get a legal opinion. Would you be willing to say? I can go out of session. Would you be able to answer my question? That's this. We will go out of session and seek opinion from legal services regarding the fact whether this bill covers the possibility of duplicate charges being denied.
Zach Brown, Legal Services. The area of the code, Title 56, Chapter 7, Section 2355, that itself does not deal or really talk about
Can't hear you.
duplication itself.
You can't hear, I'm sorry, I couldn't hear
Sorry.
you, sir.
The section of code that this amendment, or rather that this bill amends, doesn't currently deal with duplication or contemplate it.
We'll go back in session. Chairman Smith, I think that's a fair interpretation,
Mm,
and I don't think that that's what you were trying to do anyway, but go ahead, you're recognized.
I am I am thankful for your interpretation, and this is in the coverage part. And the reason there's no fiscal note is this is not requiring insurance to pay more or less. It's not taking away their ability to review and make adjustments on a case by case basis.
Chairman White.
Thank you, Chairman. I just also want to point out and thank you for bringing recognition to this. I think in that 20 counties that you mentioned, every one of our distressed counties fall in that, and many of our at-risk counties. So thank you for keeping an eye on those people who live in those counties.
I would add,
You're
if
recognized.
I might, Chairman, and thank you, Chairman White. When you were doing recruitment with ECD, one of the number one issues outside of education and access to schools is the access to healthcare. And we're trying to, with this, make sure that individuals have access to healthcare, not just within the confines of a hospital. Thank you. Happy to answer any other questions.
Members, we do have a number of questions to be asked. Kindly be brief, and Chairman Smith, kindly be brief because we do have a presentation to follow. At this time, I call upon Chairman Spicky. You recognize.
Thank you, Mr. Chairman. Just two brief questions, and you can answer them together. It's fine. First of all, I'm assuming that there are coding mechanisms to make sure that if someone goes to an urgent care facility or a freestanding emergency room or a physician's office, there are thresholds that have to be adhered to declare a true emergency. And then, well, I'll let you answer that question first. Go ahead.
Chairman Smith.
Thank you, Chairman Kumar. Chairman Sapicki, that is correct. CPT codes are once those are assigned, documentation has to match that. And so every insurance carrier employs a significant number of people. And as self-disclosure, my sister-in-law works for a major national insurance company, and that's her job. And in talking with her about this particular piece of legislation, indeed, you have to bear out in the medical record that these emergency services do match the level of care that is needed. Thank you, sir.
Thank you, Mr. Chairman.
Chairman Terry, you recognize.
Thank you, Chairman, and thank you for bringing this bill. A couple of issues that I want to bring up. One, to help kind of maybe clarify the duplicate service. Right now, if and yes, you did reference EMTALA, but if you have a patient that goes to one hospital and they're able to stabilize that patient at that hospital, say they're a heart patient, they get an EKG there, and it's an emergency at that point in time, what would be considered an emergency medical condition. I'll go over that here in just a second. But there's legitimate reason why you might get a test, whether it's a chest x-ray if somebody's going into heart failure, somebody's going into DKA and you need to get a glucose, get their potassium, and you might get that in an office or in one of these other settings and then transfer that to a higher level of care and then them get that same test for whatever reason at that other hospital. And so just because you have two tests at two different settings doesn't mean that they both weren't valid when you ordered them. And to that point, obviously, what we're covering here is emergency medical conditions. And we do know that oftentimes when patients go to the ER, a lot of things do fall under emergency medical conditions. Some things do not, and they get triaged, and it's basically they'll go see, the primary care or the nurse practitioner, whoever's in the ER, because it's not truly an emergency medical condition. But what we're covering, what it says, emergency medical condition is, means a medical condition that manifests itself by symptoms or sufficient severity, including severe pain, that a prudent layperson who possesses average knowledge of health and medicine could reasonably expect the absence of immediate medical attention to potentially result in A, placing the person's health in serious jeopardy, B, serious impairment of bodily function, or C, serious dysfunction of any bodily organ or part. And so if you have to meet those criteria, and if you meet those criteria and you're in an off-hospital setting, you are taking care of emergency services, and it should be covered. And so I applaud you for bringing this, and I will be supportive of your legislation.
Thank you, Chairman Terry. Chairman Smith?
Thank you. I renew my motion for a vote. Thank you, sir.
Very well. I think you and I discussed it yesterday, and that was very enlightening in the sense that what we are doing is adding the setup of a physician office, urgent care centers, and freestanding emergency rooms to the same coverage as would be received in an emergency room. You recognize?
I would be careful to use this word same, because I clearly don't want to mislead anyone watching this hearing and to say that you're going to be able to receive the same level of care in a doctor's office that you could in an emergency room. But as those services, as Dr. Terry just said, to stabilize the patient, if there's no other option before, that would escalate the severity or the acuity or the likelihood of mortality or, death, we want to make sure that those fall under the existing coverage plan. Thank you, sir.
Everyone knows that the level of care provided in an emergency room is not the same in a physician's office. What I meant was by way of coverage. In case a patient has a severe pain and they think it's a heart attack, it turns out not to be so, but still the coverage will be provided because in a prudent manner, a person would assume that what was an emergency to them, and they did not have a way to diagnose it. But anyway, so these two situations will be added to expand coverage from insurance, and that would not be denied. That's, to me, the basic gist of it. Members, any other questions? Questions been called. Without objection, we are voting on, I see. We have a roll call vote requested. House Bill 1752. Mr. Clerk, please take the roll.
Representatives Carr, Sapicki, Freeman, Hawk, Hicks, Hodges, Johnson, Lafferty, Mitchell, Powers, Rudd, Smith,
Aye.
Terry, Thompson, White, Vice Chair Rudder, Chairman Kumar.
Aye.
Mr. Chairman, you have 15 ayes, 0 noes, 0
Thank you,
present not
Mr.
voting.
Thank you, Mr. Clerk.
Thank you, Chairman and Committee.
The bill passes and it goes to calendar rules. Members, having finished our calendar regarding legislation today, we'll move on to presentation. It is an explanation of the PBM law that we passed, that's pharmacy benefit managers. We have 2 people who are scheduled to testify. First, we have Mr. Anthony Padillo. Am I pronouncing your name correctly? Kindly come up and have a seat. There is a microphone icon that you can push and the red light comes on. Kindly introduce yourself and state your name, and thank you for coming. Sorry. We are out of session.
We'll do a quick test. That sounds perfect. All right.
The way
Well-
I understand it, you're going to very briefly explain to us the business model of the PBM as it functions, and then you have a testimony in regards from the perspective of a pharmacist.
Yes, that is correct. I'll do my best to explain that. But yes, good morning, and thank you, Chairman Kumar and other representatives of this committee for the opportunity to attend today's discussion on pharmacy benefit managers. Is a very important issue at hand. My name is Anthony Pudlow. I'm a pharmacist, and I'm the new executive director with the Tennessee Pharmacists Association. PBM reform, enforcement of the law, it's a critical issue right now to Tennessee's pharmacists and pharmacies across the state, and really to the patients that we all serve. This problem is impacting Tennesseans in all settings, whether it's rural or urban, chain pharmacies, independently owned pharmacies, outpatient pharmacies. When we talk about the PBM business model to policymakers, the most frequent question we always get is, how is this even legal? So let me kind of start from scratch here a little bit and say PBM started as a very simple way to transmit pharmacy claims in real time to payers. What was initially an efficiency to cut cumbersome manual paper claims has morphed into an unregulated behemoth and America's most powerful and profitable companies. These companies don't provide patient care. They are not at risk like an insurer, yet these middlemen are the most profitable step in the pharmacy industry. Because there is no transparency, PBMs thrive in the confusion and the smoke and the mirrors. There is no negotiation that occurs with pharmacies and no market forces to contain them. The Tennessee legislature is no stranger to PBM reform. Over the years, the state has passed various laws to rein in on the corrupt practices of PBMs. Just last year, Public Chapter 569 was adopted by this legislature to give Tennesseans access to pharmacies of their choice without being steered to PBM-owned entities.
Excuse me, Mr. Pudillo.
Mhm.
The idea of the testimony was, what I asked you to say was, what's the function of a PBM? How does it interact with the manufacturer and the payers? And kindly describe that. I think you're describing your personal opinions that these people don't have controls or they are very highly profitable and so on. I think that's not what we were looking for.
Okay.
You see what I'm saying? Let's not editorialize. Let us give us the basic structure so members can understand what do PBMs do, what service do they provide, and how does the landscape function? Just a very simple business model description, so to speak.
Right. I'll do my best. I don't know if I can speak in full detail to say the drug pricing model that's out there. It's a very confusing model for sure. But I think the best way to look at it is, again, PBMs were developed to be a claims processor, to really assist with contracting with pharmacies across the state, across the country, and a mechanism to allow to be an entity, if you will, to provide medications and services provided at pharmacies. PBMs many times are contracted on behalf of an insurance plan to manage the pharmacy benefit, whether that might include determining what medications should be on a formulary, what tier or what copay structure may be there. Some of those services, though, I will say those can also be managed by the insurance company themselves. So some of those services are more pass through, if you will, and still ultimately the PBM is a claims processor in those cases. Is that help clarify?
Well, yeah, certainly. No, thank you. We appreciate you doing that. Go ahead and kindly finish your presentation. Then we'll have questions and we can clarify
Sure.
things further.
Sure. Like I was saying, this is definitely not something new. It's not new just for Tennessee, but for states across the country. Our colleagues over in Arkansas also recently passed PBM reform, which was fought and held up in the courts by the PBMs. They successfully then appealed to the U.S. Supreme Court. The Supreme Court then unanimously voted in favor of pharmacy. States, in fact, do have the authority and jurisdiction to regulate and enforce PBMs and their abusive business practices. The TPA is here once again to advocate for PBM reform, and we're working with a broad coalition to clean up 569 and overcome many of those loopholes and reasons that we've been seeing PBMs have been offering to the Tennessee Department of Commerce and Insurance as really why they think they're above the law. I want to emphasize the frustrations that we've heard of thousands of pharmacists in this state that continue to see the failure of PBMs in complying with the state law. Since Public Chapter 569 took effect, TPA has heard how complaints filed against PBMs to TDCI go unresolved as PBMs state their company is not based in Tennessee and therefore not bound by Tennessee law, or their plan is self-insured and not within the jurisdiction of the law. So why do we need this? We are critically reaching a tipping point for pharmacy access in the state, particularly in rural and medically underserved areas of the state. This isn't just a rural issue. It's been a recent topic in the media, and there's been significant reduction of the number of 24-hour locations, pharmacies, as well as unbearable working conditions in pharmacies and their that have pushed pharmacists and pharmacy staff to a breaking point. All of this being driven by the declining reimbursements provided by PBMs. This issue isn't new. Like I said, in 6 months that I've been here at TPA, I've heard from too many pharmacies facing gut-wrenching decisions to close their pharmacies in Tennessee communities. There's no worse feeling than to be forced to make those calls to your friends and neighbors and about closing your doors because of the current PBM business model. As a pharmacist, I became a pharmacist to help people. And it makes me sick to see what PBMs have done to my profession and the patients that I've served in my career. This is why we're here today before you. Ultimately, we need effective and enforceable legislation because it is what is right for the patient by preserving access, maintaining levels of care, and letting patients choose the pharmacy that they want without being steered to a PBM-affiliated pharmacy. I think with your support, we can really provide TDCI clear authority to enforce the laws. Our efforts, like those that are successfully being passed in state capitals around the country, are following the Supreme Court decision and bringing needed protections for the patient and fairness and transparency for the pharmacist. As you may be aware, and I believe there's copies that were passed around, TDCI released a bulletin 2101 that was issued on July 8th last year. This bulletin specifically provided guidance as the law relates to ERISA and demonstrated that, quote, self-insured entities, which would include ERISA plans, would need to be included in the requirements set forth in Public Chapter 569. States like West Virginia and Georgia have issued very similar bulletins and also putting PBMs on notice. If you don't comply with the law, lose your license. Tennessee is not alone in this fight to regulate PBMs. As referenced in a 2021 legal sidebar from the Congressional Research Service, many states have enacted legislative measures intended to hold PBMs accountable for their role in the pharmaceutical marketplace. PBMs have challenged some of these measures on the basis that are preempted by the Federal Employee Retirement Income Security Act, or ERISA, as I referenced earlier. On December 10th, 2020, in the Rutledge versus PCMA Supreme Court ruling, the Supreme Court weighed in on this issue, concluding that a state PBM law withstood preemption by the federal act. Furthermore, it states the Rutledge decision appears to signal that states may regulate the rates that healthcare providers and other entities charge for their drugs or other items and services covered by ERISA plans. I know you may be bombarded at some point by constituents or by the PBMs with scary numbers or fancy graphs. Sowing confusion is what PBMs do and how they've been able to thrive for so many years. We believe you're going to hear potentially from about exaggerated numbers that do not reflect the full picture. We have real life data right here and shortly testimony from other pharmacists in the state. I know that pharmacists sound like Chicken Little and the sky is falling, but the situation is truly dire. Without effective and enforceable reform, communities across the state are going to continue to lose access, patients will receive worsening care, and drug prices will continue to skyrocket while the fat cats keep getting richer. I know this is a very complex issue, and I can get into the weeds on this topic for hours, but I'd love to sit down with many of you, go over some of those issues in more detail and answer any questions you have. But we respectfully ask that all of you help assist TPA and the 8,000 plus pharmacists in the state and allowing them to take care of the citizens of Tennessee. Thank you.
Thank you, Ms. Budio. Members, do we have any questions? Chairman Hawk, you're recognized.
Thank you, Mr. Chairman, and thank you very much for being here. I appreciate that. I've been here 20 years and I've always been very supportive of our pharmacists and pharmacies, and I appreciate the work that you do. You made a comment that pharmacies are closing. Can you tell me how many pharmacists we've lost in Tennessee because of this issue?
Mr. Padilla?
Yeah, a great question, Representative. Unfortunately, I don't have that exact data. This has been something we've been trying to track a little bit clearer with some assistance from other stakeholders in the state, but I don't have that. More of this is just anecdotal at this point. But what we've also seen from there's a rural health institute, I think it's based out of Iowa, that provides data across the country, and that number is pretty staggering. I can get that back and follow up with you, but right now I don't have the specific numbers in Tennessee.
Chairman Hawk?
Thank you. And a follow-up, and I voted in favor of the legislation last year, very supportive of it, as was leadership within our body. It's important to make sure that we make factual statements, and I'm concerned about that. I want to hear about Tennessee specific, and that's a very alarming comment that you just made, and I want to make sure that you can quantify that. So please give me Tennessee specific numbers. Thank you very much, Chairman.
Thank you.
Mr. Padilla?
Yeah, well, I'll follow up with the representative.
Okay, you're going to provide. Members, any other questions? Chairman Powers?
Thank you, Mr. Chairman. Yes, let's talk a little bit more. You mentioned, and I'm not sure exactly what the enforcement, you were talking about that, about Tennessee Department of Commerce and Insurance. I guess they are the enforcement arm when there is a problem like that. And there seems to be an issue, based on the letter and everything, that about the ERISA plans, and maybe that this particular law that we came up with and passed last year is not being enforced. And what could we do to expedite that and make sure that these are enforced? There again, there's that conflict between the federal and the state, and so we're trying to kind of work between that and figure out which one, if we do actually have that authority, and if so, what do we need to do?
Representative Powers, just a comment on that. I mean, I think there is still a lot of assessment across the country, depending on what states have on the books, if you will, currently. I'm not going to sit here to be the utmost legal expert in ERISA, but I do know that there is a lot of assessment right now based on every state and saying, hey, from the insurance division's perspective, what can we actually do within the laws as they've been written on the books for previous years, plus how can we clean up, make sure that some of these laws actually build upon each other, I guess, would be the better way to say it. And so I know that's really been where and how many states are evaluating the ruling from the Supreme Court, is to say, okay, there's definitely some clear direction in certain aspects of state law. But then there's other things that, yes, ERISA still holds true. So that's something that this coalition is really trying to work with, not only Senator Reeves on the Senate side, but also Representative Helton as well, to make sure that we have the right language coming forward for cleanup.
Chairman
Thank you.
Powers? Chairman Smith, you're recognized.
Thank you, Mr. Chairman, and thank you all for participating today. I want to applaud this body because last year in the House, we did pass a bill that would have made enforcement and recognized the role of the licensure. It was House Bill 145 that was general subbed in the Senate, but it made very clear that we treated these entities as state jurisdictional entities, and we wanted to put some enforcement behind that. So unfortunately, it was not moved forward in the Senate. But I have a question on the mechanics of, tell us in the day of the life, we're out in Deckard, Tennessee, up in Vice Chairman Rutter's district, and there's an independent pharmacy there. And what is it, or as I understand it, pharmacies are absolutely being told that they can't price their medications at a rate that covers the acquisition cost. That's one of the practices that I'm aware of that impacts folks that are trying to keep their shingle open and not be
Right.
gobbled up by the big retailers. If you would give us a few examples, because I don't know that if
Sure.
you're not in healthcare, you don't appreciate the culture, the
Mhm.
culture war that's going on. But if you wouldn't mind, thank you, Mr. Chairman.
Yeah.
Thank you. Mr. Woody.
Representative, and I don't know, I might almost even defer to my colleague because she deals with this a lot more than I do. But maybe I'll tee it up, and if Raywin, you'd like to add, if that's okay by the committee. But I would say, yeah, a great example to your point. Pharmacies know that there's a product that they have to purchase. Many of them utilize various different wholesalers to try to access the cheapest medication or cheapest cost for that medication. I mean, this is a complex thing for every drug that's on the market, right? And so then they realize they submit the claim to the PBM. It comes back as an underwater claim or reducing less than what they had to purchase the drug at. Now, PBMs do offer an ability for pharmacies to appeal a rate that is maybe under the cost that they had to purchase the drug for. And that process sometimes can take a while. But then the pharmacy would able to resubmit the claim. Hopefully that ensures that it's shored up that it's actually at cost. But I will tell you from many of the examples, and I think Raywin here has a whole stack of them that really spell out that even the PBM may not even give back all of that. They might just pay back 1 penny more or 5 cents more, but they're still ultimately losing money on that. Raywin, I might, if it's okay, Representative or Chairman, if I can let her speak to even further.
Certainly, I don't know if we have you on the list or not, but kindly, we do. Kindly introduce yourself and add to the knowledge.
I would just give, if you have other examples. Yeah.
Okay. My name is Raywin Snodderly, and my mother and I own 2 independent pharmacies in La Follette, Tennessee. We've been in business since 1976, and she came to work at the pharmacy in 1980. Our family purchased it in 97 and then opened up a second location 5 years later. So to speak to your point about water claims, for example, in the last quarter of 2021, so October, November, and December, my La Follette store experienced $28,787 in below water claims. My Jacksboro store experienced $11,495 in below cost claims. Some of these have been appealed, and we were told that was just the contract you signed. We are often given contracts that are take it or leave it. You know, if we don't sign those, we don't have access to the patients. So that's a staggering number. Extrapolate that over 4 quarters for a small business like myself that my mother and I own. And oftentimes we're left in the situation where, you know, of course, as owners of business, we're the last. We take care of our 17 employees, all of which look at a family a size of 4 is about the average of our company. We take care of them to stay in business, but it's difficult.
Well, thank you for your input. I think the plight of the pharmacies is very important, and you serve a very valuable functions, especially in this time of COVID in our communities. Chairman Powers, you're recognized.
Yes, thank you. Could you go over a couple of things too that you were talking about as far as we get into the steering part of it, as far as steering one to another company like that? And I know that was part of the
Yes.
whole ERISA problems that we were kind of dealing with. Could you give a couple examples of those,
So-
or just talk about it a little bit?
So for
Raywin?
example, this is steering, this was a project that my colleagues and I from across the state, there were about 5 of us, put together. These are examples of pure steering by the PBMs. This isn't below cost claims. This is straight up steering. So for example, when I process a prescription in my pharmacy, I get a rejection that says maximum 2 fills, then must use mail order or retail pharmacy for maintenance medications. It's pretty black and white. The law stated no steering. These are all examples of steering. We did not look at the below cost claims because we felt like for this purpose today, it was getting really down into the weeds, but we took 4 rejection codes, and this is what we came up with. This is 5 pharmacist colleagues. Imagine the independent pharmacies across the state that did this same thing. I'm happy to share as many of these with you offline. One of the most alarming that I received a rejection the other day, and I actually have it in my red bag, if you'll hand me that. I'm sorry, I can't move very well at the current moment. I had a sledding accident. Please have customer call number on back of the card or the said, and I will say, I don't want to state this PBM's name for concerns that I will be targeted for audits, as I have been in the past, but we'll show this to you offline. But contact this said PBM, have them go to movemymedsrefills.com, as refills are not covered in your pharmacy.
Thank you. We do have, in interest of time, we can move on. We do have Chairman Lafferty.
Thank you, Chairman. I've seen a chart on this before and just wanted it to be echoed again today. Is it, if I've got it correct, is it my understanding that most of these PBMs are owned under a corporate umbrella that also owns distribution, manufacturing, and everything else that goes along with it?
Representative Lafferty, yes, we've seen that there's really three primary PBMs out there. There are some smaller as well, but many of those major three PBMs, the vertical integration from top to bottom is happening. I'm happy. I think I know which chart you're referencing and seeing the company names, whether they're owning their own insurance companies to owning their own pharmacies, their mail order facilities, specialty pharmacies. The vertical integration is definitely there.
So how, I don't know how to project a scale of this, but we're real close to monopoly, aren't we? With three big power players in this. This is what we're talking about with pharma right now.
Right.
Okay. Thank you, Mr. Chairman.
You're welcome. Vice Chair Rutter, you're recognized.
Thank you. I would like to just say that to Representative Smith's talk about Deckard, Tennessee, and small pharmacies. Yes, my husband and I use a small pharmacy in Winchester, Tennessee, and I want to thank you as a small pharmacy and as a business owner to try to keep those pharmacies open, because what I have learned by doing business with small pharmacies, they care about the individual. They cater to all the community. It is, you can go in and ask any question about anything. They're going to try to help you. They keep you much more informed, I have found, about the medication you're taking. They take a personal interest in your health. I applaud small pharmacies across this state that are trying to stay in business. I just want to make that statement. I think it's so important that we do not have monopolies, that we keep these small pharmacies in business and do whatever we can to keep them profitable. So thank you for having a small pharmacy and fighting these battles. And I will try to help you any way I can.
Do you have additional comments, or we can move on to our next?
I do have additional comments. I would like to say our pharmacies, our two locations, we partnered with the state. And I know COVID is exhausting, and I know it's worn on y'all. It's worn on us. We have a tired staff. Everybody's kind of over it. But I think it's very important for you all to know that we were the first pharmacy in Campbell County to begin administration of COVID vaccines. And one of the things that was amazing to me over this time period was we, between our two stores, have administered thousands of vaccines, not just COVID, but with that came flu and everything else. We partnered with the schools, went to every school in the county and administered vaccines to the teachers in the front lines. But the most common conversation that I had that was alarming to me was, Raywin, I would love to come to your pharmacy. I would love to utilize your services, but I can't because my insurance company makes me go to a big box store or mail order. And without community pharmacy, like myself and other colleagues that are sitting in this room with us, we are creating a public health crisis.
Thank you. If there are no other questions, we have the next person to testify, and that I have Shannon Stevenson.
Thank you.
Thank you so much.
Thank you. Sure. Chairman Hawk, personal order.
Thank you, Mr. Chairman. And I spoke earlier about being here 20 years as I'm working, and a colleague of ours from back in the day has just walked in the room. Former Representative Joe Armstrong just walked in from Knox County. Hello, Joe. Glad to have you back in. Welcome.
Thank you, Chairman Hawk. Ms. Stevenson, for the record, you know where the mic is. Kindly introduce yourself and.
Yes, sir. Can you hear me? Okay, great. Good morning, Chairman Kumar and committee members. My name is Shannon Stevenson. I am the CEO of Simpa Community Care based in Chattanooga, Tennessee, and also a location in Johnson City. We also have a mobile clinic that goes out to about 20 rural counties, and we also own an in-house community pharmacy. So I want to first of all, thank you guys for working so hard last year to pass this critical legislation. And I know that you probably have heard a lot of terms today and throughout discussing some of the PBMs, white bagging, underwater, patient steering, things of that nature. And it can be very confusing. I get it. I want to clarify some of those things for you today. And then specifically, I'm going to be talking about Section 1 of this bill because my entity is a 340B covered entity, which was a drug savings program that was brought into the federal government or passed by the federal government in 1992 to help safety nets who serve the most vulnerable in the state of Tennessee. This is our uninsured and underinsured patients. So specifically, the legislation last year prohibits a pharmacy benefit manager and other third parties from taking unfair discriminatory actions against entities and pharmacies participating in this program. PBMs, as you know, are hired to be the middlemen. They interface with drug manufacturers and process prescription-related claims. Now, how does discrimination happen? It can happen by way of reimbursement reduction. It can happen by way of added fees and adjustments. It can happen by unfair contracting based on a covered entity status. Vertical mergers continue to occur. Patients are being driven towards healthcare resources chosen by their health plan and not by their providers or the patients themselves. So just yesterday in our community pharmacy, Simpa Community Pharmacy, we had a patient with a commercial insurance plan that required these specialty pharmacy services known as patient steering. He was completely out of his life-saving medication, and we did not have any more samples in stock. The patient asked, well, is there any pharmacy that I can go to today and get my medication? Our pharmacist did not have a good answer. I encourage you to ignore the rhetoric that we keep hearing that the true cost of prescription drugs and the impact on their patients. When we have patients who need life-saving meds and they cannot walk across the hall to a small owned pharmacy and get the prescriptions they need, they are forced to go to a mail order or specialty pharmacy that can take 2 to 3 business days to process, or they can drive between 3 and 5 hours to go pick up the meds that they need that day. As some of my colleagues shared, the PBMs are virtually unregulated, and they've used this leverage to contract in ways that hurt providers in rural areas, community health centers, children's hospitals, local county governments, such as the health departments. We have very little power in negotiating with contracts with the PBMs. One of the examples that our previous testimony shared was that we're forced to sign these contracts or we'll just be out of their network. That means that any patient that comes into our clinic cannot use that pharmacy at all. I do want to speak facts and not opinions. I'm happy to share all my cited sources. I am a doctoral student, so I know the importance of that. So while PBMs profit from rebates and discounts, they fail to pass on an estimated $120 billion back to consumers. There are 3 major PBMs: They're all owned or will be owned by large health insurance companies, and they control nearly 80% of prescription drug transactions in the United States. 80%. If you look at the Fortune 500 list, you will see that several PBMs have risen in their profitability and are now attempting to usurp even more from entities that save taxpayer dollars in Tennessee for those of us who are providing charity care to those in need. The savings afforded in Tennessee further support a balanced and conservative approach while also helping citizens who cannot afford the critical health care services they need. PBMs are the middlemen, and they're looking for more ways to make money and serve as the gatekeeper to control the entire market. Despite the rhetoric around savings, prescription drug costs continue to rise at an unsustainable rate. We have all seen that. Thank you for letting me testify, and I'm happy to answer any questions.
Well, thank you. Thank you for the clarity. I know the contracts that you sign with the PBM can be long, complex, and intimidating. Have you looked at the contract to see if the PBM can do these practices such as steering or not filling refills and so forth? Have you looked at the contract to see if they're following what is in the contract?
Yes, sir. So are you asking if they are following the state law in their current contracts?
Right.
Unfortunately, because non-disclosure agreements, and one of the examples that a previous testimony shared is that we're scared of being audited or being excluded from their system at all. But I can tell you that there are still discriminatory language in our current contracts.
And on these contracts, you don't really have a choice.
That is correct, sir. We would just be excluded from their market at all. So none of our patients that have their health insurance plan would be able to use our pharmacy.
Chairman Smith, you're recognized.
Thank you, Chairman Kumar, and thank you for representing your profession well. Because of the patient population that comes to your clinic, these are people that already have transportation problems. These are people that typically have chronic disease. So they're not me or my colleague or anyone here. These are people that typically have multi-system engagement. They're on a huge list of medications, and it's not easy to go from one place to the next. Is that correct?
Yes, ma'am. That is absolutely correct. So most of our patients have comorbidities, and most of them have lifelong chronic disease.
Chairman Smith.
Thank you, Chairman. And relative to that, what you're saying is because the Tennessee Department of Commerce and Insurance is not enforcing the legislation that passed last year, your patients are being further, there's barriers that are being blocked to their care.
Ms. Stevenson.
Yes, ma'am. In fact, just yesterday, one of our patients could not get the medication that he needed. We were out of any samples that we could give this patient, and they would have had to drive 3 to 5 hours to get the medication, and it would take 2 to 3 days to come from the mail order pharmacy that they were forced to use.
Thank you, ma'am. Chairman Speaker, you're recognized.
So you touched on the process of the PBM expressing a contract to your pharmacy, and to be in, you have to take it. Is there any negotiation there between the two of you?
There can be, but it's not very strong on our part. We are your small nonprofits. We don't have the power to fight back on these big contracts. We just don't. So we can ask, but we're probably not going to get anywhere.
Chairman Speaker.
So you said that, and the previous presenters talked about how the directions from the PBM are specific of a referral to another source for meds. Are those other independent pharmacies? Are those corporate pharmacies? Are these corporate entities at the mail order? And the question is, do PBMs have ties to these other pharmacies and or corporations?
Ms.
So,
Stevenson.
yes, sir. Thank you, Chairman, and thank you, Representative. Typically, it's part of those 3 main big PBMs that are all part of a larger health system that were obtained through vertical acquisition. So to answer your question, yes, most likely they are affiliated with a mail order pharmacy that they do have a relationship with.
Last
Chairman Spick.
So it would appear, and obviously we haven't had the PBMs to come up first, and I really hope that the PBMs will step up to the microphone today and allow us to ask them some questions, because I think they should have a right to come up here and address some of the issues that have been brought forward, being the legislative body here that can affect the changes needed to make sure that our healthcare system and our pharmacy system is the best in the world. I'll leave it at that. And Mr. Chairman, I hope the PBMs will step up to the mic today.
Certainly, for balance, that would be helpful depending on time and their availability and how prepared they are. If you don't have any further questions, we have another witness, Stephen Schleicher.
Thank you, Chairman.
Thank you. Mr. Schleicher, thank you for coming. Kindly introduce yourself and
Yeah, hello. Is this on?
proceed.
Hi, thank you, Chairman. Thank you, committee, for having me here today. I'm Dr. Stephen Schleicher, an oncologist at Tennessee Oncology. I practice out in the Lebanon Clinic. And I was here actually last year when the PBM reform bill was going on. And thank you all for supporting the bill at that time. Sadly, I'm back because since that time, patient steerage away from our pharmacy has happened 400 times since July of last year. And I'm here to share some patient stories, some real patient examples about the negative impact that has had. So briefly, so I work at Tennessee Oncology. We're the largest oncology provider in the state. We have 34 clinics across urban and rural Tennessee. We take every patient that walks in the door, independent of insurance status. Spent $100 million on free drug last year for patients who cannot afford their drugs and have never sent a patient to collections. I'm also a member of TMA and the president of the Tennessee Oncology Practice Society, representing all oncologists across the state and our patients who can't be here today. So just what the process would be like when I prescribe a drug. And as most of you probably know, oral pharmacy drugs are becoming some of the most important anti-cancer drugs, which is a great win for patients in Tennessee and across the country. When I order one of these drugs, these are complicated drugs similar to chemotherapy often. I have pharmacists within our practice who focus 100% on cancer drugs. They are integrated into our electronic health system, so I can prescribe a drug, get feedback, discuss through my computer and the system about side effects I want to address, if the patient doesn't pick up the drug, if I need dose adjustments, et cetera. It all works together as part of the team. When PBMs, who own their own pharmacies, often get in the way of that, that communication is lost. With these 400 cases of steerage since July of last year, not a single one of my oncologists, to my knowledge, have ever been actually contacted by one of those other pharmacies. So the situation is broken. I want to share 3 specific examples that have all happened since last July that are 100% due to patient steerage away from our contracted pharmacy, which was in the law last year. The first is actually a patient of mine, or was a patient of mine, Mr. L.A., and I apologize, I'm going to read because I don't want to mess this up. A 59-year-old gentleman with a diagnosis of metastatic kidney cancer. He presented to me in my clinic in Lebanon late last year. I had rapidly declining strength due to his cancer, so I recommended treatment with a combination oral medicine called lenvatinib and an intravenous immunotherapy. This regimen has a 70% response rate, meaning shrinking the tumor by more than 30%, and an average length of benefit for 23 months. So this would have given significant quality of life to this patient with his family if it had worked. The patient came in for treatment with the IV medicine, which we had, and the oral medicine, which he had not received because despite me prescribing it through our pharmacy, which can get the medicine in 3 days, and my pharmacy doing the prior authorization, the patient was forced to use the pharmacy set forth by his insurance and PBM. 3 weeks later, he had still not had that drug. This was 3 weeks after planned treatment. He declined so rapidly during those 3 weeks that he was too weak for treatment and went to hospice. I didn't hear once from the other pharmacy, despite my pharmacy having to tell the patient how to contact their pharmacy. A second case, this is a colleague of mine. Miss S.A. is a 43-year-old mother. She's living today. She has a 2-year-old at home. She has metastatic lung cancer with a rare mutation called ALK that has a holy grail oral treatment against it that people are alive for years after that treatment. The treatment works with a response rate of 83%, causing significant reduction in the cancer burden and symptoms. This patient, we prescribed the drug. It took the PBM in their own pharmacy, which I actually will say was Express Scripts, 4 weeks to get the drug. In all transparency, I heard there was about a week of delay that would have been from our pharmacy as well. So let's call it a 2 to 3 week delay. During that time, her cancer, which involved the brachial plexus, which I know we have some physicians in the room, which is a nerves going through the arm, the tumor was invading that, causing so much pain that for those additional 3 weeks, the woman, our patient, was unable to even lift her 2-year-old son. The patient now has a treatment, has had a tremendous response. The pain went away in about a week, but those 3 weeks delay were purely because of patient steerage away from our pharmacy. The third case is more subtle, but this is representative of things that happen all the time due to barriers in communication when an external pharmacy, oftentimes, I won't say 100%, vertically integrated with the PBM gets in the way. This is a patient, Mr. WT, 77-year-old male with mantle cell lymphoma on an oral treatment called acalabrutinib. Apologies for that. He had been receiving his treatment from our pharmacy for months with no concerns at all, no delays, understood out-of-pocket costs, et cetera. However, before this last visit, this is a case in the last month, his insurance and its PBM required steerage to another specialty pharmacy. When the patient came in to see my colleague, all the patient's wife wanted to discuss was how difficult it was for her to get any information about the new out-of-pocket expense for this pharmacy, causing significant anxiety, and this was the whole topic of the visit with my physician. This had not existed prior when we were able to be very transparent with the patient about what their costs would be. This is a very subtle but very common occurrence that just adds unnecessary financial distress and anxiety to a patient already dealing with this difficult case. In all the above examples, the oncologist, myself in the first case, and my 2 colleagues never received a phone call once from the new pharmacy taking care of this patient. And I want to emphasize again, this has happened 400 times since July of last year, and continues to happen despite the law, which you guys worked hard to pass last year. On behalf of all patients in Tennessee with cancer and all the healthcare teams trying to take care of them, TOPS, TMA, and my partners at Tennessee Oncology ask that you please do whatever possible, and we're here to help to try to regulate PBMs to follow the law that you guys worked hard to pass last year. Thank you very much.
Thank you, Dr. Schleicher. We appreciate your testimony and clarity that you bring along with specific examples. Representative Freeman, you recognize.
Thank you, Chairman. Thank you, Dr. Schleicher, for being here and for what you do. I got to say, I'm surprised that to hear 3 testimonies that all 3 repeating that the department is not enforcing a law that we worked hard here to pass last year, and specifically in your case, a law that's meant to help protect cancer patients and extend their life and their healthy and enjoyable life. Can you answer why they're not enforcing, or what is it? Is it not clear? Is it something that we need to change?
Yeah.
Dr. Schleicher.
Thank you, Representative Freeman. So I'm the physician, so I don't know all the background, but I'll tell you what I do know. And I asked our head pharmacist last week to make sure I was up to date. And of the 400 times that we submitted complaints, 0 have been overturned. It's complicated, and I think, and I'm editorializing here, that it's not accidentally complicated how PBMs kind of deal with things. We'll submit a complaint to the insurance committee, and the response will have nothing to do with the complaint. So our focus is 100% patient steerage, but the complaint will come back about one of the other about cost versus acquisition cost of the drug. I'm getting outside of my expertise there, but most of the time the complaint has nothing to do with actual patient steerage, because I think it's a very complex kind of black box. But to answer your question directly, I don't know why, but out of 400 complaints, we've had 0 overturned in the last year.
Well, thank you, Dr. Schleicher. Were your patients, I assume, were aware of the delay involved?
Yeah, a lot of frustration by the patients. And what was more frustrating, or not more, equally, is often our pharmacists were doing the prior authorization and helping our patients figure out who to contact at the new pharmacy. So we were often the middleman for the communication because it was the right thing to do and they're our patient. And a lot of frustration when they'd come to clinic and we wouldn't have their drug available. So they were aware, but weren't getting guidance from the other pharmacy. Our pharmacy was often the one having to give guidance for the patient to help them navigate. Again, this is why a patient's waiting to start treatment for a very scary disease. So my understanding from my patients, a big gap in communication from the other pharmacy to the patient, which is the opposite of what we take pride in, trying to make sure we're there for the patient during this.
Well, certainly they're fighting a battle for life and they don't have time to take on another battle with bureaucracy, certainly. But thank you. Chairman Smith, you're recognized.
Thank you, Dr. Kumar, Chairman Kumar. Before I ask you a question, I want to just take a moment to recognize that last year, Speaker Sexton made this a big issue with that bill. And I want to recognize Chairman Helton, who carried that bill. And what I hear you say, in addition to the bill that was passed, and also we had a subsequent bill, House Bill 145, that was passed throughout the entire House, the Senate General Subject, that because this Department of Commerce and Insurance is not enforcing law that we have passed in this body, that you are not able to prioritize your patient's care, even dealing with metastatic cancer.
Yes, that is my understanding, yes.
Chairman Smith.
And let's hypothetically say that you were taken to court for some malpractice or liability that was tied to someone's premature death or mismanagement of their care. Who holds the malpractice insurance and who holds the liability for any premature death with poor treatment?
I'm scared to say, but it would be myself taking care of the patient.
Chairman Smith.
And in your experience is, for the record, and again, I know this is hypothetical outside of your maybe your expertise, because I do hope that the chairman is going to call the department forward and let us have some conversation with them today. Is it your experience that the reason the steerage is happening is because the PBMs are able to continue and keep revenue sources internally in that vertical integration that we're hearing about, or what other explanation could there be?
That is my understanding. I don't know of any other explanation.
Thank you, Mr. Chairman.
Chairman Hawk, you're recognized.
Thank you, Mr. Chairman. Dr. Schleicher, thank you very much.
Thank
We
you.
met not quite a couple years ago through Zoom, so it's good to see you last year. in
Thank you,
person.
Representative
Great
Hawk.
to see you as well. So thank you for your work. Your group does an amazing job, and thank you for all you do for our constituents. Representative Freeman and Representative Smith kind of stole my thunder a little bit. I too share concerns about Public Chapter 569 and either the interpretation therein or the implementation therein. So I share concerns, and sometimes we're very good at talking at each other, but since we do have some folks in the room, if it doesn't happen on the microphone, we'll go out in the hallway and we'll talk to each other. I would encourage that and encourage our folks from the department to have some open dialogue with folks who have expressed concerns today. It sounds like there may be some work to do on this particular piece of legislation in this particular genre to come up with some better policies to address this. But I suggest that if we don't get it played out on the microphone today, we step in the hallway and have a broad discussion about this. So thank you very much. Thank you, Mr. Chairman.
Thank you, Representative Hawk. And can I say one more thing, Chairman, if okay?
Sure.
I also want to thank, you mentioned Representative Helton, want to thank her. We had a Zoom one-on-one. I had done one with Representative Hawk 2 years ago with oncologists throughout Tennessee at 5 p.m. after work with Speaker Sexton as well. And we had 60 oncologists join just to discuss this bill, which I've never seen 60 physicians on a call at once after working hours. So these are people who don't know anything about the business model behind this. This is purely frustration taking care of patients. So thank you all for listening to us.
Thank you. Chairman Terry, you're recognized.
Thank you, Chairman. Thank you for joining us and your comments. And I just kind of wanted to reiterate some of your points. The treatments that you give in particular, and a lot of things that we do, it's patient status sensitive. what stage of cancer they're in, how fast the tumor's growing, what are the patient's vital signs this week versus, what condition are they in a 2 or 3 week delay. And so those delays, obviously, if it's time sensitive, like what you're dealing with, that's harm to the patient. The patient that you talked about with the brachial plexus issue, maybe they had to take opioids during that period of time because of the pain that they were in. Maybe because of a delay, the tumor has grown. Now it has to be debulked via some surgery or radiation or something along those lines. But then when the patient finally does get to you and their physical status is such that they're weak or weaker, and they're not as strong to handle some of the side effects of these medications, they may end up in the ER getting fluids, getting admitted overnight, which adds more cost to the system. And so I just want the members to understand that these delays, because the treatments are patient physical status sensitive, can have some consequences and ramifications. So again, I appreciate you being here today, and thank you for your service to our patients.
Thank you, Dr. Terry and Representative Terry. And to add to a great point you made, Dr. Terry, not only is everything that Representative Terry said true, in addition, our pharmacists can look into our charts. So say during 3 weeks, the kidney changes or the liver changes, they can actually help me figure out if I need to adjust that oral med, which is many times as toxic as an IV chemotherapy. So having an integrated network is crucial. And again, I've never had a phone call from a PBM owned or another pharmacy.
Representative Mitchell, you're recognized.
Yes, Mr. Chairman. I think I speak for many on this committee that we need the department in here next week. They need to explain to us why this isn't being implemented and what they plan on doing, if they plan on following the law. And if they're not, we need to take further steps to ensure they will follow the law.
Certainly, we'll do that. As a personal favor, Dr. Schleicher, would you, in private communication, put down for me the points? What are the problems? Delays in medication, steering patients to other pharmacies, or white bagging, or 5 or 6 violations or points that you see that the department can address. I think, as you can see, our committee and the legislature is very, very interested, and because the bill that Representative Helton carried last year and Speaker Sexton worked with very actively, was meant to address these issues. We are late, we have lost time, but we are definitely committed to solving the problem. And I think if you would clearly identify the points from 1 through 5 or 6, then the department would have time to prepare an answer. It will also help us to crystallize the kind of solution that we need to add in case we need to add additional legislation.
Perfect. Thank you, Chairman Kumar. I'm happy to. And I'll just clarify that the most important single point is still just steerage. Just can a patient pick up their medicine from the contracted pharmacy? But I'm happy to do that. And I'm happy to come once a week if I need to talk to anybody else here. I'm in clinic today, but my 117 partners stepped up to cover me because this is so important for our patients who can't be here.
Well, thank you. No, we appreciate your commitment. Chairman Speaker, do you have a question?
Yes, just a follow-up to Representative Mitchell's request of the department. I'd also like to request that someone from the PBMs come in here next week to also be able to address their issues and making sure that they are understanding the intent and the purpose of the law that we pass.
Very well, thank you.
Am I allowed to, can I say one more? I'm sorry, I didn't mean to interrupt.
Sure.
So just because the PBMs will say that they're saving money, I just want to clarify. Tennessee Oncology, we saved Medicare $5 million last year. We're in a total cost of care money. We take risk for costs. We're in the largest commercial oncology medical home in the country with Blue Cross of Tennessee, who has been a great partner to us as well, to try to save money and be rewarded for quality. So we are aligned on lowering costs for patients. I know the PBMs will say that, but I have not seen evidence of that yet.
And lastly, Chairman Smith, we appreciate your contributions to the matter. Go ahead.
Thank you. And I want to applaud our committee chairman for arranging this hearing today. We appreciate you, Dr. Kumar. One thing, just to prepare for expected hearings for next week, in Tennessee Code annotated 567-3113. It references that no person or entity shall administer medication or device, and this is talking about benefit, pharmacy benefit manager coverage in this state unless the person or entity has obtained a licensure through the Department of Commerce and Insurance. There are several references in this one little section, committee, that PBMs are indeed licensed. Fees are collected by our Department of Commerce and Insurance. And so I look forward to hearing explanations, as does the entire committee, on why the governance and the jurisdiction to enforce and affect law is so troublesome. Thank you, Chairman Kumar.
Thank you. Members, any other questions? Seeing none, we are setting an example of finishing in time. We'll go back into session without objection.
Thank you, everyone.
Any questions? Okay. If seeing none, we stand adjourned.